Welcome to the deep dive. Right, today we're taking a really close look at modern orthopedics, focusing in on the crucial point where cutting-edge clinical work meets, well, the tough realities of operational strategy. Because let's be honest, to deliver top-quality care these days, especially at scale, like just being a brilliant surgeon, frankly, it's only part of the picture. So our goal here is to give you those key insights you need, whether you're, managing a practice that's growing, tackling a complex revision, or overseeing rehab for multiple patients. We'll be covering the big picture stuff like the challenges facing large orthopedic groups, think vertical integration, growth models, and then drilling right down into the clinical detail. Things like LIRA, specific rehab protocols for really complex hand injuries, and the latest thinking on joint replacements.
Yes, absolutely. And I think it's really vital, isn't it, to frame this by saying that the whole sector is going through, well, an immense amount of change. Clinical skill, obviously essential, but it doesn't guarantee success on its own anymore, not by a long shot. With the move towards value-based care, the pressure for efficiency, it just demands this tight integration of clinical and operational strategy. So we'll be looking at how the leading practices are actually managing this enormous complexity, whether that's, say, getting IT systems to talk to each other across multiple surgery centers, or, making sure that multidisciplinary approach truly works when you're dealing with something like a major limb reconstruction. It's all connected.
Okay, let's kick off with where many feel the pressure most acutely right now, the business side of things, especially for those larger orthopedic groups trying to expand. There are some significant hurdles, aren't there? Experts, people like Charles Bush-Joseph at Rush University Medical Center, part of the Orthoforum, they've really pinpointed the key business challenges. So perhaps you could outline the top, say, 3 strategic hurdles these ruling groups are facing.
Yes, certainly. Bush, Joseph, and others consistently highlight 3 sort of core strategic pillars that practices absolutely have to get right if they want to scale effectively, but also, crucially, keep control and stay profitable. The first one, and you could argue it's the most pressing right now, is the drive towards vertical integration of care. And the main force behind this, it's the shift to bundled payment models. These are becoming much, much more common across different payers. Essentially, what a bundled payment does is it makes the surgeon or the practice financially responsible for everything, the whole patient journey, from the first consult through the operation, the implant cost, the hospital or the ASC stay, right through to typically 90 days of rehab and follow-up.
Wow, so the risk profile changes completely. If you don't control all those different bits, the surgery center, the physio, the imaging, you're suddenly taking on a huge amount of financial risk. That sounds incredibly complicated to manage.
It is. It's extremely complex. The practice needs to achieve a level of control over costs and quality at every single step. Think about it. If a patient goes for physiotherapy outside your integrated system, you've lost control over the cost of that therapy and the quality of it. And both of those things directly impact your bottom line and your outcome metrics under that bundle. So vertical integration, it's not just about making things convenient. It's actually a fundamental mechanism for managing financial risk and making sure you hit those strict quality targets that payers are demanding. Without that control across the whole pathway, succeeding with bundled payments is, well, it's almost impossible.
That makes perfect sense. Control is basically a prerequisite for managing cost and quality in that world. Okay, let's move to the second hurdle. This is about how practices actually grow. What's the best way?
Yes. The second challenge is figuring out the optimal model of growth. This is a constant calculation for practices. What's the right size to cover the market effectively so you can negotiate properly with payers, but also achieve internal efficiencies? The path they choose here really defines their future. And there are several options on the table. Do they look at partnerships or mergers with smaller groups to get scale quickly? Do they bring in outside investment, perhaps from private equity? That gives you capital fast, but you might give up a lot of control. Or do they just stick with slower organic growth, which preserves their autonomy, choosing the wrong route? Well, you could end up big but inefficient, or efficient but having lost your clinical independence. Balancing speed, capital, and long-term control, that's a huge strategic task for the leadership team.
I can only imagine the debates that go on internally around those choices. And the third challenge you touched on, compensation. That often feels like the most sensitive nerve within a practice, doesn't it? How does growth make attracting and keeping top surgeons more complicated?
Ah, yes, the third challenge. Compensation and ownership. Highly, highly sensitive. Traditionally, orthopedic pay was pretty straightforward based on individual clinical work, the fee-for-service model. Simple enough. But as practices get bigger and move toward these more sophisticated value-based contracts, the money coming in depends more and more on how the group performs overall. On quality scores, on efficiency, across that whole care journey we talked about, not just how many procedures one surgeon does.
So how do you keep everyone motivated, especially the high performers?
That's the million-dollar question, isn't it? The real challenge is designing a pay structure that does two things at once. It needs to maintain a strong incentive for the individual surgeon who's bringing in a lot of work and delivering great quality coding. You still need them driving revenue, but it also needs to create a powerful collective incentive for the whole group to hit its financial targets and quality goals. If it's too focused on the group, your star surgeons might feel, well, undervalued or even penalized. If it's too focused on individual output, then there's less motivation for people to get involved in those important but time-consuming quality initiatives or mentoring junior partners.
Finding that sweet spot.
Exactly. Getting that balance right is absolutely critical if you want to attract and, just as importantly, keep the best people in what's a very competitive market.
Hashtag 1.2, the technological and operational ecosystem. It's clear that tackling these big challenges, the integration, the growth strategy, those delicate compensation models, it all needs a much more sophisticated setup behind the scenes than, say, 10 years ago. It's not just about scalpels and implants anymore, it's the management tech, too. So what kind of technologies and perhaps specialist service partners are actually helping practices meet these demands?
You're spot on. The clinical side is now underpinned by this really complex operational ecosystem. We're seeing the rise of very specialized support services tailored specifically for orthopedic groups, covering everything from the moment a patient first contacts a practice right through to, believe it or not, real estate strategy. Take revenue cycle and patient access, for instance. This has become much more about the patient experience, hasn't it? Practices need systems that really embrace this shift towards consumer-driven healthcare. You see platforms like Health, here with the Clinic Q system, offering things like cost estimates before the visit, flexible payment options, simplifying the whole intake process using mobile apps.
Making it smoother for the patient.
Yes. But crucially, these systems have to plug seamlessly into the practice's existing electronic health records, the EHR, and the practice management, or PM, systems. The goal is really twofold. One, get rid of that waiting room time nobody likes sitting around filling forms, which is a huge source of patient dissatisfaction. And two, dramatically cut down the admin burden by automating things like checking insurance eligibility and collecting co-payments before the patient even walks in the door. That kind of efficiency is vital for managing costs, especially in that bundled payment world.
Okay, but getting those slick mobile apps to talk reliably to the core EHR and PM systems, that sounds like a massive IT job in itself. What sort of specialist IT support is needed for that backbone?
Oh, it's profoundly complex. This isn't something a general IT provider can usually handle well. Orthopedic groups need specialized IP support that understands healthcare compliance, security, and managing huge amounts of data. They need people who are experts in their specific PM or EHR software, dedicated database administrators, DBAs, to look after all that sensitive patient data, and report writers who can actually pull out the meaningful quality metrics that payers demand. And security and compliance, non-negotiable, especially when you've got data spread across main offices and maybe several ambulatory surgery centers. This need has really pushed practices towards specialist partners, like reliable IT healthcare, because general IT support often just doesn't have the specific expertise for the regulatory and data challenges in modern orthopedics.
Right. And beyond IT, what about the physical stuff? Supplies, managing the ASC efficiently.
Absolutely. Managing costs in an ASC, for example, it all comes down to efficiency. So medical surgical distributors like McKesson play a really critical role. It's not just about delivering gloves and gowns. They help manage inventory, cut down waste, which is crucial for cost control, and they offer solutions like custom procedure trays. These are prepackaged kits with everything needed for a specific operation, say a total knee, tailored for the ASC environment, streamlines the whole process.
And then there's the financial side, again, managing those complex bundled payments and maybe even the group's longer-term financial health. That needs its own specialists too, presumably.
Definitely. The financial structure of a large group is complicated. You have firms like Fusion 5 that specialize just in navigating the complexity of bundled payments, making sure everything's tracked correctly, reconciled properly across the whole episode of care. And the really savvy practices are looking beyond just the immediate clinical income. Groups like CMMA help physicians set up and manage their own physician-owned real estate, turning the buildings they practice in into stable, long-term investments. That kind of financial diversification, looking at the property aspect, it's often a sign of a strategically mature group.
Interesting. And finally, given the nature of orthopedic surgery, risk management must be a constant concern.
It has to be. In high-volume orthopedics, standard malpractice cover often isn't enough. You need customized insurance products and orthopedic-specific risk management services. Partnerships with firms like Mag Mutual and OFIS provide this. They go beyond just insurance. They offer proactive advice on how to mitigate risks, specifically related to joint replacement, spine surgery, complex trauma, the high liability areas of orthopedics.
Okay, let's look at a really concrete example of these operational shifts in action. The move of more complex procedures, particularly total joints, into ambulatory surgery centers, ASCs. How is this playing out in terms of efficiency and maybe even patient experience for joint replacement programs?
Yes, the migration of procedures like total knees, total hips, and now even some spine cases into ASCs, it's not just a trend, it's really a fundamental restructuring. And it's driven by clear benefits, both clinical and operational. The advantages of setting up a strong total joint replacement or TJR program in an ASC are pretty compelling.
Hmm.
You typically see much greater surgical efficiency, fewer delays, faster room turnovers, because the environment is purely focused on orthopedic workflow, unlike a busy multi-specialty hospital.
Right, less competition for theater time.
Exactly. And this often translates into a better patient experience, faster recovery, lower risk of hospital-acquired infections, and patients often feel they get more focused attention. But, and this is key, just moving the surgery isn't enough to maximize efficiency. The entire patient pathway needs to be redesigned for the ASC setting. This is where specialized comprehensive support programs come in, like the Positive Connections Initiative from Smith plus Nephew, for example. They don't just supply the implants. They provide dedicated support for things like developing robust patient selection protocols. This is critical, making sure only the right, lower-risk patients are done outside the hospital. They help optimize the day-to-day operations, the logistics, make sure the billing and revenue cycle management is tailored for ASCs, and provide specific training for the whole team.
So it's really about standardizing everything around the procedure, not just the surgery itself, that unlocks the efficiency.
Precisely. Standardization is the absolute key. By carefully controlling patient selection, the implant supply, the workflow, the ASC minimizes all the variables. And this loops right back to that first challenge we discussed, vertical integration. The ability to tightly manage the cost and quality of that entire TJR episode is massively enhanced when the surgery happens in a physician-controlled ASC environment. This kind of specialized wraparound support is what enables an ASC to go beyond just doing the joint replacements and actually achieve peak efficiency and the best possible outcomes.
Okay, let's pivot now from that sort of macro system level view down to the intricacies of clinical excellence in a really challenging area. Let's focus on the hand. Managing complex hand trauma is incredibly demanding, isn't it? Because the impact goes so far beyond just the physical injury. Our hands are just so vital for everything: communication, expression, work, daily life. How should we think about the profound impact of these injuries, looking beyond the obvious medical damage?
Yes, it's absolutely essential that everyone involved, orthopedic surgeons, plastic surgeons, therapists, GPs, recognizes that a severe hand injury isn't just a localized problem. It is, without doubt, a systemic health issue that cuts deep into a patient's psychological state and their social functioning. If we only focus on fixing the bones and tendons, we're missing this huge, long-term psychosocial burden that these patients carry. Hashtag tag 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 2.1, the profound impact of complex hand trauma. The negative psychological fallout can be staggering. Patients very frequently suffer from significant anxiety, clinical depression. They can become socially isolated and experience a really marked, often lasting reduction in their overall quality of life. The severity varies, of course, but it often correlates quite closely with how bad the injury is and how permanent the disability might be. We're not just talking about feeling a bit down. We're talking about persistent, potentially debilitating psychological conditions.
You mentioned specific psychiatric issues. Is there evidence that people with severe hand trauma are more likely to develop certain disorders compared to, say, people with injuries to other parts of the body?
Yes, the data on that is quite compelling, actually. Patients who suffer these really complex, life-changing hand injuries, think mangling injuries, crush injuries, they show a substantially higher likelihood of developing the full criteria for post-traumatic stress disorder, PTSD, compared to patients with many other types of trauma.
Really? PTSD specifically?
Yes, it seems the sudden, often violent nature of the injury, combined with the loss of function in a part of the body so central to our independence and identity, makes it particularly traumatic psychologically. And alongside PTSD, we often see other issues cropping up. Things like cognitive difficulties, problems with concentration or memory, and chronic sleep problems are quite common. And these, of course, make it even harder for the patient to engage with the demanding rehabilitation process.
What are the main things driving that distress? Is it the pain, the loss of function, the appearance? And how does that psychological state then impact their physical recovery?
It's really a combination of factors. Firstly, there's often persistent pain, and sometimes it's neuropathic pain, which can be incredibly difficult to treat effectively. Secondly, the sheer frustration and dependence caused by the limited functional ability is immense. And thirdly, we shouldn't underestimate the impact of disfigurement. Visible scars or deformities can severely damage self-esteem and body image. Patients often feel very self-conscious, which can lead to avoiding social situations. And crucially, there's a very strong, demonstrable functional link between how someone is feeling mentally and how well they recover physically. Studies consistently show that higher levels of psychological distress, anxiety, depression directly correlate with poorer results in terms of hand function and overall quality of life scores down the line. If someone is highly anxious or deeply depressed, they're often less likely to stick with the intensive therapy programs, which unfortunately leads to worse stiffness, less function, and greater long-term disability. So you absolutely have to manage the psychological side to maximize the physical outcome. They are intertwined.
So, if the mental and physical recovery are that tightly linked, it really underlines that working in silos just isn't going to cut it. Why is that multidisciplinary team approach absolutely essential for getting the best long-term results?
It's essential simply because the damage is too complex for any one person to handle alone. You think about it, you've got bone, joint, tendon, nerve, skin, soft tissue damage, plus the psychological trauma, plus the social disruption. No single specialist, however brilliant, can effectively manage all of that simultaneously. Optimal recovery has to be holistic. It must address the physical, the psychological, and the social aspects together, ideally from the very beginning. So let's break down who needs to be on that collaborative team, and they really need to function as a single unit. You've got the orthopedic and plastic surgeons. They handle the physical reconstruction. Orthopedics focusing on the skeleton and joints. Plastics on the soft tissue envelope, skin cover, often microvascular repairs. They have to work hand in glove, quite literally sometimes, often needing immediate flap coverage over complex bony fixation.
Okay, the surgeon set the stage.
Then you have physicians. It could be the GP or other specialist. Their role goes beyond just the initial diagnosis. They manage medications, especially complex pain regimens, deal with any underlying health issues, and this is critical. They act as the gateway for early referral, for psychological assessment and support. Getting mental health input early, not months down the line when problems are entrenched, is key.
Right, proactive referral.
Absolutely. Then, central to the whole process are the hand therapists that's typically specialist occupational therapists or physiotherapists. They are absolutely vital co-pilots in the recovery journey. Occupational therapists, OTs, focus specifically on restoring function for daily living, getting dressed, eating, working. They're brilliant at finding adaptations and often integrate coping strategies for pain and anxiety directly into functional tasks. Physiotherapists, PTs, tend to focus more intensively on the specifics of regaining range of motion, strength, flexibility in the tissues. They might also use things like relaxation techniques to help break that pain-anxiety cycle.
So very complementary roles.
Very. And then, of course, you need the psychiatry or mental health professionals. They provide the expert support and evidence-based treatments for the anxiety, depression, or PTSD that, as we said, can completely derail recovery if left unmanaged. And finally, don't forget the social workers. They are often the unsung heroes, helping patients and families navigate the incredibly complex healthcare system, access benefits, find vocational support, all essential for getting back to some semblance of normal life.
Okay, let's zoom in on the most severe end of the spectrum, those devastating mangled hand or severe crush injuries. These often need multiple surgeries over months, sometimes even years. Can you walk us through the typical surgical sequence starting right at the beginning and really highlight why the therapy afterwards isn't just follow-up, but absolutely integral to the success of the surgery itself?
Yes. The management pathway for these catastrophic injuries is incredibly complex, starting with the absolute immediate priorities in the first few hours. Initial salvage and damage control. The first step, non-negotiable, is prompt and thorough debridement, removing all dead or non-viable tissue. We're literally racing against the clock here, particularly with muscle tissue. Devascularized muscle only survives for about 4 to 6 hours. That's the warm ischemia window. Miss that and the muscle is gone.
So time is critical.
Absolutely critical. At the same time, you need skeletal stabilization.
Mhm.
often initially with external fixation. This isn't just for pain relief. It provides a stable framework that's essential to prevent any kinking or stretching of delicate nerves or blood vessels that you might be trying to salvage or repair later. And the initial approach has to be somewhat cautious, because the full extent of the tissue damage, especially where viability is borderline, often isn't clear for a few days. This frequently necessitates planned second-look operations for further debridement and then starting the reconstruction.
Right, so you stabilize and clean up first. Then, assuming the hand is salvaged, the long-term battle is often against scarring and stiffness, isn't it? What do the later surgeries typically involve?
Exactly. The recurrent challenges after these injuries are dominated by fibrosis, extensive, dense scarring that binds everything together, causing severe soft tissue adhesions and joint contractures. So the subsequent surgeries, and there can be many, are often focused purely on restoring passive movement that's been lost to this scar tissue. This typically involves procedures like tenolysis, surgically freeing up tendons that have become completely encased in scar. This might be needed for the extensor tendons on the back of the hand, like the EIP or EDC, or the flexor tendons in the palm. Alongside that, you often need joint releases, which means performing capsulotomies, cutting the thickened joint capsule and releasing tight collateral ligaments to physically unblock the joint's movement.
Okay, so you surgically free everything up. Now, explain that critical link to therapy. Why does it have to be immediate?
Right, this is where the concept of the critical link is so important. Immediate postoperative therapy is not just advisable, it is mandatory, and it must start, well, almost immediately, often on day one after the tenolysis or joint release surgery. Why? Because the moment the surgeon has surgically achieved that improved passive glide of the tendon or freed the joint, the body starts laying down new scar tissue again, incredibly quickly. If you wait even 48 hours to start moving it, those early, flimsy adhesions will start to form and quickly mature, basically sticking everything back down again.
Undoing the surgery.
Precisely. It completely neutralizes the surgical effort.
Yeah.
So the therapy, the immediate controlled movement, is the active process that maintains the space and glide created by the surgery. It prevents those adhesions from reforming. Therapy isn't follow-up, it's the essential consolidation of the surgical gain.
That's a crucial point. Now, in really severe cases where the trauma destroys intrinsic muscles within the hand, you can't restore normal function without rerouting other working muscles' tendon transfers. Can you give us some examples of the more complex transfers needed when the standard donor tendons might also be damaged?
Certainly. In these severe mangling injuries, where intrinsic muscles are lost and perhaps common donor tendons like palmaris longus or even some FDS tendons are gone, you need really creative, highly tailored solutions to restore basic grip and pinch. One major problem is clawing of the fingers, where the MP joints hyperextend due to loss of the intrinsic muscles. To counteract this, we use anti-claw tendon transfers, a classic procedure, the Zancali lasso procedure. Here, you might take the flexor digitorum superficialis, or FDS, tendons from, say, the long and ring fingers. You split each of these into 2 slips, giving you 4 slips in total. Each slip is then passed through the A1 pulley at the base of its respective finger and looped back onto itself, suturing it under tension.
So it acts like a dynamic check crane.
Exactly. It creates a dynamic tenodesis. When the patient then fires their main FDS muscle to bend the fingers, this transfer provides active flexion force at the MP joint, stopping it from hyperextending. This allows the long extrinsic flexors, FTT, to then effectively bend the PIP and DIP joints, restoring a functional grasp.
Clever rerouting. What about restoring pinch power if the thumb muscles are gone?
If you lose the thumb adductor muscle, which is vital for powerful pinch, you need a thumb adductorplasty. A common technique is to use the FDS tendon from the index finger. You detach it distally, reroute it across the palm, and anchor it to where the adductor plossus muscle normally attaches on the thumb. This restores that critical ability to bring the thumb forcefully across the palm for strong pinch.
And what if specific fingers are stuck, say the little finger pulled inwards?
Yes, sometimes you get specific deformities. For instance, a severe adduction contracture of the little finger can be surprisingly disabling. It makes it hard to grasp large objects or even put on a glove. In that situation, you might perform a small finger abductionoplasty. This could involve rerouting the path of the little finger's own extensor tendon, the EDC, more toward the ulnar side to give it an abducting pull, correcting the deformity. These are just examples, but they illustrate how, after massive tissue loss, surgery have to find ways to repurpose the remaining functional muscles to restore at least basic essential hand functions. It's highly personalized reconstruction. Hashtag 2.4 rehabilitation protocols and nerve injury management.
That intricate surgical work, especially the tendon transfers and repairs, clearly demands equally precise rehabilitation. Let's focus on flexor tendon repair is notoriously tricky, walking that fine line between the repair rupturing and it getting stuck down with adhesions. Can you break down the evidence-based rehab stages starting right after surgery?
Yes. Flexor tendon rehab, especially in the critical zones A and 2 in the fingers and palm, is highly protocol-driven, precisely because of that narrow therapeutic window. The immediate post-op phase is all about protecting the repair from rupturing. So the protective phase lasts from day 0 up to about 4 weeks. During this time, the only thing holding the tendon together is the suture material itself. Therefore, any movement protocol has to stay strictly within the tensile limits of that suture repair. This is why we use early controlled motion protocols, like the Duran, Kleinert, or more modern approaches like Nantong or relative motion. These are typically started very early, often within just 3 to 5 days after the surgery.
Why so early? Doesn't that risk the repair?
It seems counterintuitive, but there's a physiological reason. It relates to something called the work of flexion, WOF. This is basically the amount of force the patient needs to generate to actively bend their finger against the resistance caused by swelling and edema. Research suggests that this ROAS is actually at its lowest around 5 days post-op before the swelling really peaks. By starting gentle, controlled motion very early, we take advantage of this window. It promotes that crucial tendon glide, helps prevent those initial adhesions from forming before the finger gets really swollen and stiff, which would then require much more force to move later on.
That makes sense. Move it while it's easiest. How is the hand typically protected during this phase?
Standard protection usually involves a dorsal block orthosis, DBO, a splint worn on the back of the hand and forearm. This keeps the wrist bent forward slightly, and the main finger joints, MCPs, also flexed, which takes tension off the flexor tendon repair. For certain repairs, particularly FTP tendons in zone 1 or 2, a more sophisticated approach is using relative motion flexion, RMF orthosis. These clever splints position the operated finger's MCP joint at about 30 to 40 degrees more flexion compared to the adjacent uninjured fingers. This subtle difference in relative position encourages differential gliding between the repaired tendon and its neighbors, maximizing excursion while still protecting the repair site.
Okay, so very specific splinting. What happens after that initial protective phase?
After about 4 weeks, you enter the transitional phase, around 4 to 6 weeks. By this point, the initial scar tissue is starting to mature and gain some strength, so you can begin to slightly increase the tensile demands on the tendon, but still very cautiously. The therapist carefully assesses how well the tendon is gliding to guide progression. Then, from about 6 weeks onwards, you move into full mobilization. As the tendon repair gains more intrinsic tensile strength, you gradually increase the forces applied, often following principles like Groth's pyramid of progressive force application, starting with gentle active movement, then blocking exercises, then light resistance, and eventually building up to normal use.
That detail on the work of flexion is fascinating. Okay, shifting focus slightly to bone injuries. What does the evidence tell us about rehabilitating common metacarpal fractures, especially after they've been surgically fixed with plates and screws?
Well, for metacarpal fractures, specifically thinking about the 2nd to 5th metacarpals, the main shafts, the overall quality of evidence for rehab protocols is a bit mixed. However, there is a really important piece of Level 1B evidence from a well-conducted, randomized controlled trial, RCT. This trial directly compared traditional supervised physiotherapy in a clinic setting versus a carefully designed home exercise, HE program, that patients followed independently after ORIF for these fractures.
And what did it find?
Quite remarkably, it found that the structured home exercise program was not just as good as, but actually statistically significantly more effective than the traditional physio approach. The patients doing the home exercises showed better overall hand function scores and, notably, significantly greater improvement in their finger range of motion, specifically the digital total active motion, or TAM. The p-values were highly significant. PA 0.00001 for function, PO 0.013 for TAM.
That's a huge finding. It suggests we could potentially save resources and empower patients more.
Exactly. It has massive implications for how we allocate therapy resources, potentially reducing costs and giving patients more control over their own recovery. Now, it's important to note this finding specifically applies to surgically fixed fractures. For fractures managed non-operatively or just with temporary K-wires, the general principle remains early active mobilization guided by the surgeon and therapist.
Okay, very interesting. Finally, let's touch on nerve injuries. We know nerves regenerate incredibly slowly, maybe a millimeter a day. How does sensory reeducation actually help the brain make sense of the signals coming back from the healing hand?
Yes. Nerve recovery is notoriously slow and often incomplete. Sensory re-education is the crucial process we use to essentially help the brain relearn how to interpret the jumbled or faint signals that start coming back as the nerve fibers regenerate. It's about reprogramming the brain's sensory map for the hand. Early phase training should ideally start as soon as possible, even when the hand feels completely numb or is just starting to get some odd tingling sensations. The key principles are frequent, regular, and repetitive practice. The process often involves using multiple senses at once. For example, the patient might look at an object, touch it with their affected hand, perhaps feel it with their unaffected hand simultaneously, maybe even describe it verbally. They are constantly comparing the input from the injured side to the normal side.
Trying to recalibrate the brain's interpretation.
Precisely. This simultaneous multisensory input helps the brain to remap that specific area in the sensory cortex corresponding to the damaged nerve territory. That's also absolutely vital to educate patients about safety during this time. Because they have lost protective sensation, the ability to feel pain or dangerous temperatures, they're incredibly vulnerable to accidentally burning themselves or sustaining other injuries without realizing it.
Good point. And presumably you need specific splints to support the hand while the nerve recovers, depending on which nerve is injured?
Yes, absolutely. The functional loss is quite distinct for each major nerve, and splinting is key to prevent secondary problems. For a radial nerve injury, the main problem is loss of wrist and finger extension, a wrist drop. So a resting splint is needed to support the wrist and fingers in a functional position and prevent the extensor tendons from becoming overstretched while waiting for recovery. With an ulnar nerve injury, you lose power grip and fine motor control, and often develop that characteristic claw-hand deformity due to intrinsic muscle paralysis. So an anti-claw splint is essential to block MP joint hyperextension and allow the long flexors to work more effectively. And for a median nerve injury, the big issue is loss of thumb opposition and sensation in the key pinching digits. A functional positioning splint is needed here to maintain the thumb web space and keep the thumb positioned for potential pinch, preventing contracture until nerve function returns, if it does.
Okay, we've seen the need for precision in hand surgery and rehab. Let's broaden out again and look at how technology is driving precision across orthopedics more generally. It feels like we're in the midst of a real sea change with things like robotics and AI becoming more integrated. Beyond just surgical accuracy, how are these advanced technologies transforming practice?
Yes, the transformation is significant, and it's starting to shift decision-making from being purely reactive to becoming more predictive and proactive, which is really exciting. In the operating theater itself, the adoption of robotics and navigation is definitely maturing. You hear about major centers hitting milestones like performing their 10,000th robotic-assisted total joint replacement. That tells you it's becoming embedded in high-volume routine practice now. The precision these systems offer, particularly in achieving really accurate implant alignment and joint replacement, can be difficult to consistently replicate by hand, even for experienced surgeons. And we're also seeing things like augmented reality creeping in, where vital information is overlaid directly onto the surgeon's view of the operative field. It brings the planning data right to the bedside, as it were. So, enhancing the surgeon's capabilities in theater, but you mentioned a shift towards predictive care. Where does AI fit in? Right. I think the truly transformative potential, arguably, lies outside the operating theater, and that's where artificial intelligence, AI, and machine learning, ML, are making inroads, especially in post-operative care. We're seeing AI-driven remote monitoring systems emerge. These use data from wearable sensors, think smartwatches or specific monitors, to analyze a patient's recovery in real time after surgery. The clever part is the machine learning algorithms. They can be trained to detect very subtle deviations from what's considered a normal recovery pathway, maybe slight changes in gait pattern after a hip replacement, or reduced activity levels, or a plateau in range of motion improvement.
Spotting problems earlier.
Exactly. The algorithms can flag these subtle warning signs, prompting the clinical team to intervene much earlier, before a potential complication like an infection or stiffness really takes hold and becomes a major problem. It's about minimizing complications through early detection. And in the research field too, AI and ML are having a huge impact. They can automate incredibly time-consuming tasks like systematic literature reviews or analyze massive patient data sets to identify patterns and predictors of outcomes far faster and potentially more accurately than human researchers ever could, accelerating evidence generation.
The potential certainly sounds enormous, but getting these advanced technologies widely adopted must come with significant challenges, surely. What are the main hurdles practices face?
Yes, the potential is there, but the barriers are very real. There are two main ones, and they often go hand in hand. The first is the financial investment. It's considerable. We're not just talking about the initial cost of buying a surgical robot, which is substantial in itself. There are also ongoing costs for maintenance contracts, often expensive specialized disposables required for each case, and sometimes significant upgrades needed to the hospital or ASC infrastructure to support the technology and the data it generates.
So a big capital outlay and ongoing cost. What's the second hurdle?
The second major hurdle is the substantial learning curve. You can't just buy a robot and expect surgeons and staff to use it effectively overnight. Adopting robotic surgery or learning to effectively use complex AI diagnostic or monitoring platforms requires intensive specialized training. It needs dedicated time away from clinical practice for surgeons, theater nurses, technicians, data analysts. It requires developing new workflows, new protocols. It's a major long-term commitment of both time and resources. Frankly, that could be extreme.
Okay, let's shift gears again, moving from hardware and software to the biological frontier, regenerative medicine. This holds out the promise of actually restoring damaged tissues rather than just replacing them. But it often feels like an area where the hype can sometimes outpace the solid clinical evidence. Where are we seeing real advancements, and perhaps more importantly, where are the biggest challenges in terms of reliability?
Yes, regenerative medicine is definitely an exciting field, aiming to harness or boost the body's own healing powers. Stem cells are still a major focus of research here. Mesenchymal stem cells, or MSCs, are particularly interesting because they can differentiate into various musculoskeletal tissues, bone, tendon, cartilage. Sources like Wharton's jelly from umbilical cords are being explored as they seem particularly promising and avoid some ethical concerns.
And what about using the patient's own cells?
Well, that's where the real cutting edge lies, with induced pluripotent stem cells, iPSCs. The concept here is revolutionary. You take a patient's own ordinary cells, like skin cells, and essentially reprogram them genetically back to an embryonic-like state. From that state, they can then, in theory, be guided to develop into almost any cell type you need for repair bone cells, cartilage cells, tendon cells. While it's not yet widely used clinically, the huge potential advantage is that because the cells are the patient's own, you minimize the risk of immune rejection. It offers the prospect of truly personalized biological repair.
Fascinating potential. Now let's talk about something that is widely used but still generates a lot of debate. Platelet-rich plasma, or PRP. You mentioned earlier that its evidence base is hampered by mixed results. Why is PRP so inconsistent in practice? What's the core problem?
PRP. Yes, it's incredibly popular, and there's certainly some promising data suggesting it can help accelerate healing, particularly in soft tissues like tendons or ligaments.
Yeah.
But its clinical usefulness is fundamentally undermined by one major issue: a critical lack of standardization. Well, PRP is essentially a concentration of growth factors and platelets taken from the patient's own blood. But there is simply no universally agreed-upon recipe for how to prepare it. The process involves spinning the blood down in a centrifuge, but the variables are huge. How fast do you spin it? Do you spin it once or twice? That dramatically alters the concentration of platelets and also white blood cells, which might be pro-inflammatory. Do you add chemicals to activate the PRP before injecting it to make it release its growth factors? If so, which ones? And what final concentration of platelets are you actually aiming for? We don't have clear answers or agreed standards for any of this.
So different clinics could be injecting vastly different biological products, even though they all call it PRP.
Precisely. If you go to Clinic A, they might use one commercial kit and preparation method, while Clinic B uses a completely different system. The end product they inject could be biologically and chemically quite distinct. And this massive variability makes it incredibly difficult to conduct high-quality clinical trials and pool the results. If the treatment itself isn't consistent, how can you draw reliable conclusions about its long-term effectiveness or safety? This lack of standardization is the single biggest bottleneck holding back PRP from becoming a truly reliable, evidence-based treatment modality.
That clarifies the issue perfectly. Okay, moving beyond cells and plasma, what about tissue engineering approaches, specifically for bone repair?
In bone regeneration, the really interesting developments involve integrating synthetic scaffold materials with powerful biological signals. So you might take a 3D printed scaffold designed to perfectly match the shape of a bone defect and infuse it with biological factors like bone morphogenetic proteins, BMPs. BMPs are potent molecules that actively stimulate bone-forming cells to grow into the scaffold. This combination aims to provide both the immediate mechanical support needed and the biological stimulus to encourage robust, natural bone healing within that structure. It's about combining structure and biology.
And looking even further ahead, what about things like gene therapy? Is that on the horizon for orthopedics?
Gene therapy is still largely experimental in orthopedics, but it holds tantalizing potential, particularly for conditions like osteoarthritis, OA. The research focus here is often on trying to modify the disease process itself, rather than just treating symptoms. For example, researchers are exploring ways to deliver genes directly into the joint that could inhibit key inflammatory pathways. If you could locally suppress pro-inflammatory molecules like interleukin-1, IL-1, or TNF-alpha within the joint cartilage, you might be able to actually slow down or stop the cartilage degradation that defines OA. It's a long way from routine clinical practice, but it represents a potential future direction aimed at true disease modification.
Right, let's bring our focus back to arthroplasty, and specifically to unicompartmental knee arthroplasty, or UKA. For a long time, UKA was viewed with a degree of caution, mainly because registry data often showed higher revision rates compared to total knee arthroplasty, TKA. Is that perspective changing? What's the current thinking on who is suitable for a UKA?
Yes, there's been a significant shift in thinking, driven by better data analysis, particularly from high-volume surgeons and modern implant designs. The traditional narrative around high revision rates is increasingly being challenged by the clear functional advantages that UKA can offer the right patient. Hashtag NATAG 4.1, the expansion of unicompartmental knee arthroplasty, UKA. The argument now, supported by good evidence, is that UKA could actually be a suitable option for a much larger proportion of patients with knee osteoarthritis than previously thought, potentially up to 50% than some estimates, provided the disease is truly confined to one compartment. And the benefits for those patients can be really compelling. Compared to a TKA, UKA is significantly less invasive. It preserves the cruciate ligaments, which are crucial for normal knee kinematics, and it spares healthy bone in the other compartments. Operative time is shorter, hospital stays are typically shorter too, and perhaps most importantly, patients who have a successful UKA often report that their knee feels more normal. They're more likely to achieve that elusive, forgettable joint because the natural mechanics of the knee are better preserved. That's something less commonly reported after TKA.
Okay, so if the potential benefits are that clear, why were the selection criteria historically so narrow, often restricted to younger, thinner, less active patients? And why does some registry data still seem to show higher revision rates for UKA?
Well, those traditional, very restrictive criteria, things like patient age under 60, weight under about 80 kilos, low activity demands, they're actually quite poorly supported by the current evidence base. We now see UKA as a valid option across a much wider spectrum. For younger active patients, it can be a great alternative to something like a high tibial osteotomy, preserving bone stock for the future. And perhaps surprisingly, for selected older patients, the reduced physiological insult compared to a TKA can be a significant advantage, leading to lower morbidity.
So broadening indications. But what about those revision rates? How do we interpret that data?
Right. Interpreting the registry data on UKA revisions requires a bit of nuance. There are really four key factors to understand why UKA revision rates can appear higher than TKA rates. First, the threshold for revising a UKA is often lower. If a patient with a UKA develops some pain, or perhaps arthritis progresses in another compartment, both the surgeon and the patient might be more willing to proceed to a revision, usually converting it to a TKA, compared to facing a much more complex revision of an existing TKA.
Okay, it's seen as an easier next step.
Exactly. Second, related to that, the actual conversion of a UKA to a TKA is technically much less challenging and requires less specialized equipment than revising a failed TKA. So again, the barrier to deciding let's revise it is lower. Third, we have to consider patient demographics. UKA patients, on average, still tend to be younger and more active than TKA patients. Simply by virtue of having more years of active life ahead of them, their lifetime probability of needing a revision due to wear or other issues is statistically higher. And fourth, and this is probably the most critical point, surgeon volume matters enormously. Registry analyses consistently show that revision rates for UKA are significantly higher, reportedly up to 4 times higher for surgeons who only perform UKAs occasionally, say, for less than 5% of their knee replacement cases.
So it's a procedure that requires specific expertise and regular practice.
Absolutely. The bad outcomes, with long-term survivorship rates that rival TKA, are consistently seen with high-volume surgeons, those for whom UKA constitutes a substantial proportion, maybe 40% to 60% of their total knee replacement practice. It really underscores that UKA isn't just a simpler TKA, it's a distinct procedure that requires dedicated experience and volume to achieve optimal results.
Whether it's a UKA or a TKA, arguably the most feared complication, the one that can completely derail success, is periprosthetic joint infection, or PJI. It's devastating for the patient, obviously, and incredibly costly to manage. What are the key evidence-based strategies that need to be implemented before surgery, often involving multiple teams, to minimize the risk of PJI?
PGI prevention is a huge focus, and rightly so. And it absolutely doesn't start on the day of surgery. It starts weeks, sometimes months, beforehand. And it requires real multidisciplinary collaboration involving the GP, potentially dentists, dietitians, and anesthetists, not just the orthopedic team. The goal is to identify and aggressively manage every known modifiable risk factor before the patient even gets near the operating theater. We can group these risk factors. First, there are the general modifiable risk factors. This includes things like getting tight control over chronic conditions, especially metabolic diseases like diabetes. We need strict targets for blood sugar control, typically looking at HbA1c levels. Managing systemic inflammatory diseases like rheumatoid arthritis is also crucial. Nutritional optimization is vital. Patients who are malnourished, perhaps with low serum albumin levels, are known to be at significantly higher risk of infection. Weight management is important too, as obesity is a major risk factor. And standardized protocols for bacterial decolonization, often involving nasal swabs and antiseptic washes before surgery, are now routine in most centers.
Are there any other general factors that are sometimes overlooked?
Yes, two that definitely warrant specific attention. First is identifying and treating anemia preoperatively. Low hemoglobin is an independent, modifiable risk factor for PJI that must be addressed before elective surgery. Second is ensuring dental clearance. It might seem unrelated, but there's a clear documented link between poor oral health, particularly active gum disease or dental abscesses, and the risk of bacteria seeding a joint replacement later on. So getting the dentist's okay is necessary.
Okay, those are the general health factors. What about factors specific to the joint itself?
Yes, there are local factors to consider too. This includes things like strictly avoiding intra-articular steroid injections into the knee or hip joint in the months leading up to surgery, as this can increase infection risk. It's also important to carefully assess any history of previous surgery or interventions on that joint. Things like previous arthroscopies might affect skin condition or bacterial load. Implementing preoperative physiotherapy, sometimes called prehab, can be beneficial too. Getting the joint as strong and mobile as possible beforehand may help with post-operative recovery and potentially reduce complications. And then, of course, right at the end, rigorous, standardized skin preparation protocols in the operating theater itself remain the final barrier. Hashtag tag 4.3 novel assessment in rotator cuff repair and limb salvage.
Okay, let's move to the shoulder for our next point. Rotator cuff repair is common, but we know that re-tear rates can be frustratingly high. You mentioned that standard imaging, like MRI or ultrasound, sometimes struggles to give the full picture, particularly with something you termed failure with continuity. How are researchers developing ways to assess the structural integrity of the repair more precisely and objectively after surgery?
Yes, standard imaging like MRI and ultrasound is pretty good at showing a large, obvious re-tear, a full-thickness defect, where the tendon has pulled completely off the bone again, but is much less sensitive at detecting or quantifying a more subtle but equally important failure mechanism, failure with continuity, end quote. This is where the tendon might still look broadly intact on the scan, maybe with some thinning or partial tearing, but crucially it is significantly retracted medially, pulling away from its original footprint on the bone, even though there isn't a complete hole. This retraction effectively lengthens the muscle tendon unit, reduces its mechanical advantage, and often leads to poor function, even if the scan doesn't show a full re-tear.
So the connection is still there, but it's stretched out and ineffective.
Exactly. To get an objective measure of this retraction, researchers have developed a technique using radiopaque markers. During the initial rotator cuff repair surgery, tiny, inert metal markers, which show up clearly on CT scans, are sutured securely onto the surface of the repaired tendon, just medial to where it attaches to the bone. Then, post-operatively, the patient undergoes serial CT scans over time. By precisely measuring the distance between these implanted markers and fixed bony landmarks on the humerus, you can get a very accurate, objective measurement of exactly how much the tendon has retracted over time.
That sounds much more precise. What have the studies using this marker technique actually found? And what does it mean for how we should be managing patients after a rotator cuff repair?
The findings have been quite revealing and, frankly, a bit sobering. They really highlight the limitations of relying solely on standard imaging or clinical assessment. One key study using this technique found that some degree of tendon retraction occurred in all patients followed up. The average retraction was quite significant, around 13.4 millimeters by 2 years post-op, and importantly, most of this retraction happened relatively early, within the first 6 months after surgery.
So it's an early phenomenon.
Yes. And here's the really striking finding. Over half, 53% of the patients in that study whose repairs were classified as intact or only having a partial thickness retear based on standard MRI or ultrasound, still showed meaningful tendon retraction of more than 10 millimeters when measured accurately with the markers. This strongly suggests that the degree of tendon retraction gives us much more sensitive information about the true biological and mechanical integrity of the repair, and likely correlates better with long-term function than simply classifying it as intact or torn on a standard scan.
What are the immediate implications of that? Should we be changing rehab protocols?
Well, the immediate implication is that we probably need to rethink our postoperative management and surveillance. If significant functionally relevant retraction is occurring this frequently, even in repairs that look intact on MRI, especially within those first crucial 6 months, it suggests we need to look closely at our protocols during that period. Perhaps current rehabilitation protocols are allowing too much strain across the repair site too early for some patients. Or perhaps we need better ways to protect the repair biomechanically during that critical tendon-to-bone healing phase to minimize the tension that drives this retraction. It certainly challenges us to refine our approach based on this more objective measure of healing integrity.
Fascinating. Okay, to conclude our clinical deep dive, let's consider the challenge of limb salvage, particularly after severe trauma leading to lower extremity non-unions where the bone just hasn't healed. In these complex situations, often with bone loss or infection, when is attempting limb salvage a viable alternative to recommending an amputation or perhaps a joint replacement?
Limb salvage in the face of complex lower extremity non-unions, especially after high-energy trauma, represents a real pinnacle of orthopedic trauma and reconstruction surgery. It is definitely a viable alternative in many cases, but it requires a highly committed patient who understands they are embarking on a potentially long, multi-stage, and demanding treatment pathway. The techniques involved are highly specialized, especially when dealing with significant bone loss. For large bone defects, say more than 5 or 6 centimeters, simply using standard bone graft isn't usually sufficient. You often need large volumes of autologous bone graft of the patient's own bone. This is frequently harvested using a reamer irrigator aspirator (RIA) system.
How does that work?
The RIA allows the surgeon to safely ream the inside of the patient's femur or tibia, collecting large quantities of high-quality, morselized cancellous bone graft through a suction and irrigation system with a relatively minimal morbidity at the donor site compared to traditional iliac crest harvesting.
So you get a lot of graft material. What if there's also a limb length discrepancy?
That's very common after a severe trauma. If you have both a large bone defect and significant limb shortening, surgeons can employ even more advanced reconstructive techniques. This might involve using a custom-designed synthetic graft cage, often 3D printed, to bridge the bone gap and restore the correct length acutely. This cage then acts as a structural scaffold, providing immediate stability, and it's packed full of that RIA-harvested autograft, potentially mixed with other bone substitutes to provide the biological stimulus for healing. This combined approach allows you to address both the bone void and the length discrepancy simultaneously. It's complex surgery, often requiring multiple stages for debridement, soft tissue coverage, bespoke fixation, and prolonged recovery. But for the right patient, preserving their own limb, even if it requires this level of reconstruction, can offer superior long-term functional outcomes compared to amputation or complex arthroplasty, justifying the significant effort involved. Hashtag tag outro.
Well, we have covered a huge amount of ground today, haven't we? Really mapping out the complexities of modern orthopedics. We started right up at that strategic level, looking at the financial pressures driving things like vertical integration, the tough choices around growth and compensation models in large practices, and the operational precision needed to make high-volume joint replacement work efficiently in the ASC setting.
Yes, and then we dove right into the clinical detail. We talked about the absolute necessity of a multidisciplinary team for managing the devastating impact of complex hand trauma, both physical and psychological. We unpacked the mechanics and timelines of flexor tendon rehab, and we looked at the evidence suggesting we should perhaps be expanding the use of UKA, at least for high-volume surgeons. And I think the core theme that kept emerging is that operational skill and clinical innovation are now completely inseparable. You can't really succeed without both working in concert. They are the twin engines driving better, measurable outcomes for patients.
We also saw how technology is giving us much more granular insights, whether it's AI potentially flagging post-op complications earlier, or those radiopaque markers revealing the hidden story of tendon retraction after cuff repairs, forcing us to question and refine our standard protocols. The focus has to be on rigorously applying this growing body of evidence to streamline care and make it more personalized for every patient. If you found this deep dive valuable, please do take a moment to rate and share the show. It really helps us reach more colleagues who are also striving for excellence in their practice.
And perhaps a final thought to leave people with. The increasing sophistication and success we're seeing in reconstruction, whether it's complex hand surgery, congenital differences, or these major limb salvage efforts after trauma, it really does fundamentally shift our expectations. Our ability to successfully reconstruct rather than resort to amputation, it challenges the next generation of orthopedic surgeons, doesn't it? It continually pushes us to redefine what constitutes an acceptable functional recovery, driving the boundaries of what's surgically and functionally possible ever further.